Welcome to Emergency Insights. I'm your host, James Carter. Today, we're focusing on a topic that comes up frequently in emergency medicine, the management of cellulitis. This update draws on the most recent evidence and best practice recommendations to support sound, efficient decision-making in the ED. Let's walk through the key points. First, let's talk about blood cultures. For patients who are systemically well with cellulitis, routine blood cultures are not recommended. They rarely alter management and often do not yield useful information. However, there are specific circumstances where blood cultures should be considered. These include patients who appear systemically unwell. For example, those presenting with fever, lymphangitis, persistent tachycardia, tachypnea, or hypotension. Blood cultures are also appropriate for immunosuppressed individuals, such as patients with active malignancy on anti-cancer therapy or those with known or suspected neutropenia. Next, regarding imaging. Routine imaging is not necessary in straightforward cellulitis cases. However, point-of-care ultrasound, PoCUS, can be incredibly helpful when there is uncertainty in distinguishing between cellulitis and a potential skin abscess. There are select situations where further imaging like X-rays, CT, or formal ultrasound should be considered. These include suspected osteomyelitis, the presence of a foreign body, or clinical features that raise concern for necrotizing fasciitis. It's important to note, though, that imaging should never delay surgical consultation if there's clinical suspicion for necrotizing fasciitis. Time is critical in those cases. Now, when should we initiate IV antibiotics? There are three clear indications. First, if the patient is systemically unwell. Again, think fever, lymphangitis, unstable vital signs. Second, if there is treatment failure with oral antibiotics. This means the patient has persistent or new fever, worsening pain, or spreading erythema after at least 48 to 72 hours of appropriate oral therapy. And third, when oral intake is not feasible due to vomiting, malabsorption, or similar concerns. Elevation of the affected limb should not be overlooked. Advising patients with limb cellulitis to elevate the area is a simple, effective adjunct. It facilitates gravity-assisted drainage of edema and inflammatory mediators, supporting a quicker resolution of symptoms. Lastly, consider the role of NSAIDs. As an adjunct to antibiotic therapy, a short course of oral NSAIDs, typically for 5 to 7 days, can be beneficial, assuming there are no contraindications. Evidence from randomized controlled trials suggests that NSAIDs may enhance clinical response by day 3, although they do not appear to impact overall cure rates up to 22 days. Of note, this benefit has not been demonstrated for corticosteroids in the same setting. To summarize, don't order blood cultures or imaging routinely. Reserve these for specific indications. Use PoCUS judiciously. Start IV antibiotics in systemically unwell patients, those with oral treatment failure, or those who cannot take oral medications. Encourage limb elevation, and consider NSAIDs as a short-term adjunct when appropriate. Thanks for tuning in to Emergency Insights. I'm James Carter. Stay sharp, stay focused, and as always, take care out there.